This session is on interventions beyond coronaries, because as we are seeing that the cardiologists have gone beyond coronaries. So Dr. Pramod Kumar, who is the Chief of Interventional Cardiology at Fortis now at Shalimar Bagh, he is a very seasoned and very senior cardiologist now, and he has done a lot of interventions beyond coronaries, which is iliac arteries, subclavian arteries, carotids, and maybe much more. So Pramod, please.
Thank you, Praveen. A very good morning to all of you. And first of all, my thanks to Dr. K.K. Agrawal and Dr. Pawan Gupta. It's always an honor to be invited by them. Now, as Praveen rightly mentioned, we have started venturing out of coronaries because there are other vascular beds which are equally affected and they need attention. I'm presenting this on behalf of the whole team which I work with, and which is always very essential for me to do these complicated procedures. What I'm going to tell you briefly is about the peripheral vascular disease, the iliacs, the superficial femoral artery interventions, below knee interventions, aortic aneurysm, stereoaneurysm repair, just a brief glimpse of all these, traumatic abdominal AV fistula, carotid and vertebral interventions. This is a site I'm sure all of you must have seen, the non-healing ulcers. This is one of the advanced stage of peripheral vascular disease, and this is something which needs attention, and I can assure you that if you treat them in time, you will never see these things again. It's a very well-known fact that the vascular beds in the body, with the three main vascular beds, the coronary, the cerebrovascular, and the peripheral arterial disease, the disease is actually an overlap, and this is actually a pan-vascular disease. And it has been shown that almost 30% of time you will have disease in more than one vascular bed. So if you have one vascular bed affected, you must always look for problems in the other vascular bed. And I can tell you that these are not benign conditions. The mortality is higher, cardiovascular disease is higher, coronary artery disease is also very high. The combination of diabetes with peripheral vascular disease is a very well-known combination. And I can tell you that at the end of 15 years, only 10 to 15% of the people survive. So this is a deadly combination you must be aware of. Risk factors are almost similar to what you see in coronaries and cerebrovascular disease, but smoking and diabetes play a much more important role. Just want to highlight two parts of this slide, that if you have a person who has presented with peripheral vascular disease, major amputation is going to take place in almost 4% of these patients, and of all the deaths, cerebrovascular and cardiovascular disease is going to be responsible for almost 2/3 of these patients. So what are the goals of therapy in peripheral arterial disease? The most important thing from a clinical point of view is to identify whether they have an additional problem for coronary and cerebrovascular. And then the second is to prevent progression of the disease and amputation, and as I have shown you. So how do we proceed? Clinical examination, ankle brachial index, peripheral arterial Doppler. CT angio is extremely important. It gives you a whole picture and it helps us in actually strategizing our strategy how to go ahead with the therapeutic intervention. Conventional angio and DSA is what we get next. Major issue is a CTO, what we call a chronic total obstruction, huge long obstructions, long standing. They are the biggest problem, and it's very difficult to actually cross them. There are very many newer devices that are available, what we call dedicated re-entry catheters, then there are special atherectomy devices. They're very expensive. So what we have done actually is a slightly innovative technique that we have started treating these patients retrogradely, whether through transfemoral, transfemoral, or transaxillary approach. And I'm just going to show you some of those examples. This is a 45-year-old male smoker, 20 years, with a non-healing ulcer, and this is what his CT scan showed. You can see here, this is a long gap in the superficial femoral artery in the thigh. From the mid-thigh, it starts forming again, and this is the below knee, which is totally, destructed disease. So what we did here was that we actually punctured in the middle of the thigh. The femoral artery was punctured, and then we were able to put a wire through that. And then once a wire was crossed, we went into the aorta. As you can see here, the wire is being crossed into the aorta. And the moment we crossed into the aorta, we made a puncture on the right side and snared this wire, as you can see here. Can we have the lights down, please? I'm sure it's not very nicely visible. The wire is snared, as you can see here. It has been caught by this snare, and we are pulling it out of the right side. This will give us a railroad over which all our interventions can be done. This is being pulled out, as you can see here. And moment we pull it out, we have a railroad, and then we can easily put our stents from the other side. As you can see here, the whole artery is now reconstructed. Very nicely, goes right up to the knee. This guy started feeling the benefit of it in just about a month. His ulcer healed. Now, this is a very challenging case which we did. Took us about 8 hours to do it. 48-year-old male, anterior MI, CABG was done. He also had peripheral disease for which a bypass was done. The bypass closed in just 1 month's time. And this, he had a huge non-healing ulcer with osteomyelitis for almost 6 years. He was confined to bed on the verge of suicide. This is actually the ulcer which he had, an extensive ulcer. This is actually a little after the healing had started after doing the angioplasty. So this guy had a total obstruction. You will just see that the femoral artery is blocked here. The whole length of femur, there is nothing, and it reconstructs with collaterals in the upper part of the tibia. And it goes right. We could detect the posterior tibial artery, which is going there, and this is where we punctured the posterior tibial artery. I'll just show you a little example. This is where we punctured. Actually, this is the place where we punctured, and put a wire. Now, this wire you can see here is going up. This is a very special wire, atraumatic wire. From below upwards is going up, and we were able to cross the whole length with the help of this wire. And then once the wire is crossed, we were able to, we actually needed to put 6 stents in this guy. Even after putting stent, you can see there is a lot of thrombus throughout the stent. We did everything to take out the thrombus. We couldn't do that. So we put him actually on 24 hours of intra-arterial thrombolytic therapy, which worked wonders. And the next morning, after 24 hours, he had bounding pulse. He was so much tired after this procedure that he didn't allow us to take the final picture. But this is after 3 months. His leg is completely healed. This guy is back on his feet, driving, working. Now, this is another a case where we did recently, another case where we punctured the posterior tibial artery, and we were able to cross and do the whole procedure without any problem. This guy again had total blockade. You can see here, this is a arteriogram from below upwards. The whole arterial system below the knee is all right, but the total obstruction of the femoral artery. And this is what we were able to reconstruct completely with a large, long 150 millimeter stent in the femoral artery, and the whole arterial tree in the leg has been completely reconstructed. This is another very challenging case which we had recently, CTO of right subclavian and brachial artery. We did a trans-axillary approach because there was nothing else we could had an access to. You can see here there is this complete blockade of the subclavian artery, then there is a complete blockade below the brachial artery. So what we did here was that this is the place we punctured the axillary artery because this was the only accessible part. We couldn't actually cross the lesion from the femoral artery. It was so calcified that we were not able to cross, so we decided to go retrogradely again. This is where we punctured, and this is the angiogram from the side. You can see there is a big gap, but the next one will show you that we were able to again cross with the same wire. It's a very special wire which we use, not very expensive, and we were able to cross the lesion and then reconstruct the artery. We were able to put a stent and could get a antegrade flow. After the antegrade flow, we went from the femoral again and reconstructed the whole of the brachial artery. His radial and ulnar are still, but he has got tremendous, benefit from it. He's working. His hand is now back. He's a worker. He's a factory worker, so he's back to his work now. This is an orthopedician who had, again, very severe disease. Here we did a popliteal puncture. He had again, complete blockade of the femoral artery, not able to cross from the above downwards. So we did a popliteal puncture. We have abandoned this procedure now. For popliteals, we don't puncture because the popliteal vein is there, and we get into, easily get into a form of AV fistula. So we don't do it now. We are back to puncturing the anterior tibial. And again, this guy had, he needed 3 stents, and we were able to reconstruct his artery right up to the knee. He improved tremendously. His ulcers healed, and he's back to his work. Now, this is a deliberate subintimal approach. Sometimes what happens that if you're not able to cross through the main lumen, you go subintimal and then get back into the lumen. This is what a lady, 78-year-old lady, what we did was we punctured the wire into the subintimal space. You can see here the dye is in the subintima. And with a locally formed needle, we went back into the true lumen, and we were able to, as you can see here, we were able to cross, and we put a stent, and the whole artery is again reconstructed here. So what I have shown you here is that it's possible to take care of all these long-standing chronic total obstructions. And I can tell you with a lot of confidence that whatever problems they have in form of non-healing ulcers, pre-gangrenous conditions, this I'm talking of chronic limb ischemia. I'm not talking of acute limb ischemia. All of them will heal, with the caveat that the stents will close in about 1/3 of the cases. But in spite of the closure of these restenosis of these stents, it has been shown that all these ulcers will heal, the patients will get back to his feet. So any person who has this kind of problem can be tremendously benefited by the modern approach. Now, just a few examples of other things which we did. This is a huge abdominal aortic aneurysm in an Iraqi lady who had come to our hospital with almost 6.5 centimeter on the verge of bursting. And what I was showing you previously is that this is a surgical procedure initially where we cut down, and this is the stent which we put is a what we call something like a pajama stent, where you can see that the whole abdominal aneurysm has completely collapsed. And this lady is doing very well with repeated aortic, CT angios, which we do for follow-up. Now, this is again a very interesting case we did. A guy who had come to us with a chronic cough, recurrent hoarseness of voice, recurrent laryngeal nerve palsy, because of this pseudoaneurysm in the ascending, in the arch of the aorta. Again, we put covered stent here, and this was completely gone, and this guy improved tremendously. And this is vertebral artery multiple blocks with posterior cerebral syndrome. And this is what we did. We had to put 4 stents, but again, the whole of it was reconstructed nicely, and the gentleman improved. Traumatic hepatic artery fistula after gunshot wound. You can see here, this is what the fistula is, shown in the different views on CT angio. We put what we call a vascular plug here, and we could close it. This is a 3-month follow-up. And you can see that it's completely closed. So what I've shown you that it's possible to take care of most of these other vascular bed problems, whether it's secondary to atherosclerotic process or secondary to trauma, which leads to aneurysms, pseudoaneurysms. So the cardiologist has ventured out, and the techniques which we have learned over a period of time taking care of the coronaries can be utilized very successfully in other vascular beds with excellent results. Thank you very much for your kind attention.
I'll just request Dr. Ganesh Mani also to join on the stage for the panel discussion. We have 5 minutes for the panel discussion. Dr. Ganesh Mani. Dr. Praveen, all yours.
Yeah, I think these were very wonderful cases which are now possible with the new interventional hardware and, of course, expertise which Dr. Pramod showed. Are really, helpful to the patient and to, of course, improve the outcomes in these severely atherosclerotic patients. And generally, people ask why cardiologists have started doing all this. This is one of the questions, and because nobody knew a cardiologist will do all these things. Only because, we were very curious, because many such patients who had atherosclerosis in the heart would come up with problems in the leg or in the arm or in the carotid arteries. And I'll tell you, only yesterday, we did an angioplasty about 3-4 days back, coronary stents, and everything was fine. The lady was going home, and yesterday she said, now I'm not able to walk for, 5 minutes. So we said, you never told us that you are not able to walk. She said, but earlier I was having chest pain, now I'm having leg pain. So then we did an angio last evening. We found that the iliac artery is also blocked. So she is now due for an angioplasty of the leg arteries, which will relieve her symptoms. So basically, we are now atherosclerosis specialists rather than coronary specialists.
Any questions from the audience? it's very simple thing is that if a patient comes to me with coronary artery disease, he's having angina, should as a routine we do a carotid Doppler and a peripheral Doppler and a renal Doppler.
Yes, that should be the ideal situation, that you must, evaluate all the vascular beds. But, if the cost is involved in it, definitely
The cost
then you
is
can...
much less than the cost of angio.
Oh, yes, of course, I'm
No,
not
no,
talking of
Doppler
angio
echo.
at all. No, I'm not advocating angio in these patients. I never do that. But if you go, if there are symptoms, then you must always. But there are certain guidelines that, for example, people who have got diabetes, people who have been smoking for a long time, then you must always evaluate the other vascular system. And there's a very simple device, what we call an ankle brachial index, that gives you an idea whether you need to proceed to do further tests like Doppler and other things or not. So these are things which are available in your clinic. You must be able to do that. So if you have a suspicion...
So if we do 1,000 angio with positive blockages, how many of them will have associated peripheral vascular disease? How many of them will have a renal vascular disease? How many of them will have carotid vascular disease? If you do 1,000 triple vessel disease.
I think, we did one study, we did a study on renal arteries actually, and the incidence of renal artery stenosis was about 10%. But the important issue is that not all of these renal artery stenosis are actually leading to problems. So they don't need any treatment.
Peripheral vascular disease?
And peripheral vascular disease is again 10 to 30% incidence.
10 to 30%.
Yeah,
And the statistician says if the incidence of anything is more than 1%, general screening is advisable. That's what the statistician says.
But I will say one thing, that rather than doing investigations, I think a good history taking is one of the most important things in any patient who comes with either any evidence of atherosclerosis, whether it is angina or whether it is peripheral vascular disease. We should take the history of the patient very carefully, whether his blood pressure is getting controlled on 2 drugs or 3 drugs, or not getting controlled at all, and also if he has claudication, if he has angina, if he has TIA, so those can be taken out by history also.
Dr. Mani, why it is important that every patient who bypass, we need to do a carotid Doppler? Before doing bypass, why do you insist on doing a carotid Doppler?
This was more in the era when we were doing open heart surgery. When we used to put the patient on heart-lung machine, they would have non-pulsatile flow, and if they have carotid stenosis as well, they would probably end up with a stroke. So, but in these days of beating heart surgery, we're not so keen because nothing happens because the carotid flow is maintained. However, if there is bilateral carotid artery stenosis, and even if the patient is asymptomatic, and if one of them is more than 90%, we would probably attend to the carotids before doing coronary artery bypass.
Any other questions from the audience? Identify yourself and just speak the question.
I'm Dr. Golecha from Noida. Dr. Pramod has said that the stents which they have used would get blocked in 3 months' time. Still, it helps in healing. So my simple question is, when we are using for coronaries the drug-eluting stents, can we also use it for the other arteries blocks? Drug-eluting stents.
Yes, sure.
And if they are used, that will be lasting for a longer period.
Till now, these drug-eluting stents are not commercially available for use in peripheral artery disease. The studies have been completed, phase 3 studies have been completed, and they have shown excellent results of long-term, patency. Hopefully, in next 1 year, these stents will be available. Till now, these studies were conducted with small size stents.